Welcome to this talk, and welcome back to Professor Robert Clancy from Australia. Professor, thank you so much for coming back on.
Well, thank you very much, John, for having me.
Now, we want to do an update because a lot of people are unhappy about the safety of COVID vaccines, which is one issue. But today I want to focus on the efficacy of COVID vaccines. Now, there's some data being published that shows that COVID vaccines might not be helpful in preventing hospitalizations, but actually causing more hospitalizations. Is this true, and does it make any theoretical sense?
It's a very good question, John, and I think it's an issue that we've really neglected. We often talk about the many adverse events of messenger RNA vaccines, but what has been neglected is what in fact has happened in real life. And this is not a surprise. This is something that should have been predicted right at the beginning. It was something that happened with influenza. It was shown that if you vaccinate a person with influenza and use the same vaccine 12 months later, the amount of immune response is about 20-25% less than you got the year before. In other words, this whole business of down-regulating and suppressing, turning off immunity by too many vaccines combined with exposure in the environment to the COVID virus was predictably going to cause what we're now seeing today.
So we've kind of got a double exposure now. We've got a lot of people still getting these vaccines, and we've got regular exposure to the COVID antigen. How is the immune system reacting to that? And what's this whole idea of negative immunity? How is it occurring on a physiological basis?
Well, there's been a lot of talk around the topic of negative immunity, and I think people mustn't be surprised. There's all sorts of comments that would suggest, oh dear me, we're getting more infections, not less. Vaccines are supposed to prevent, not promote infection. You need to understand the reasons for this. The COVID virus is an inhaled virus. It's not one that gets into the bloodstream as part of its natural pathogenesis. It actually is breathed in and handled by a system we've talked about before, the local mucosal immune system. And the key part and the elephant in the room with mucosal immunology is the fact that it is a very balanced type of immune response and requires to have mechanisms to turn off the immune response so you don't get an exaggerated inflammatory response to every virus and every pollen and everything else that you breathe in. This is quite different to the immune system that's operating in the bloodstream, which is geared to sterility. The bloodstream immunology system is aimed at neutralizing every virus particle, because otherwise you have a system that could be overwhelming and lethal very quickly. So we've got this system. So we know. Now, if you keep getting a particular virus, and remember, the patients all of us who are getting COVID from time to time, have been getting the parent virus, the coronavirus, probably all our lives. So in other words, the body's been sensitized basically to the coronavirus. And so when you get a vaccine which comprises part of that virus, the spike protein, then you're not essentially immunizing in a totally naive way. And so the response you get is not just a good positive response, although initially you will get a positive response, but as experience goes and as you get more exposure to the virus in the environment, and as you get more of these booster vaccines, particularly after about 3 of them in a year or 2, you actually get a net turn off rather than a net turn on. So instead of getting terrifically vigorous immune response, which initially when the vaccine rollout occurred, there was a very good protective immune response. But progressively, that immune response has become less and less, which means that there's less and less protection from the vaccine, and the dynamic that needs to be understood, John, is a dynamic that involves three components. The first component is the virus itself, and the virus is changing. Every 6 months or so, we get a new variant.
Yeah.
The second variant is the vaccine virus, the virus they put in the vaccine. And despite the warp speed nature of making these viruses, they're always lagging behind. In other words, when a new vaccine comes out, it's usually two, or very often up to two major virus changes away from the virus that's in the community. And the third variable, and this is the one that has not understood and hardly ever discussed, and yet it's so important, is the population's resilience and response, the population's immunity. And so what you've got is two major things happening. You've got vaccines continually being given and continually driving down the immune response, while at the same time it's lagging behind the virus that's prevalent in the community. And so when you put these two things together, the actual protection becomes progressively less, which is called negative immunity. Now, interestingly, John, I think the first time I saw this, although it didn't surprise me, was in England. And you might remember way back in 2022. It seems like an eon ago, doesn't it? Yeah. 2022. But in 2022, you'll remember that the British government used to publish the protection rates of the vaccine and what was happening. I think basically every week. Then all of a sudden, negative immunity started appearing, and at the same time, so did the reports of what was going on. So the authorities have known about this for 3 years.
Yeah, they just stopped reporting it.
They stopped reporting it. And the same occurred in my own state of New South Wales, when suddenly most of the people in hospital were the vaccinated people as opposed to the unvaccinated. And all of a sudden our reporting stopped. So we have this system that each time a new vaccine comes out, someone will do a 2 month, maybe 3 month study and show, compared with the 80% protection against hospitalisation and even death when the rollout occurred back in 2021, they get something like 30 or 40% protection. But they only look at it for 2 months. And have you got that graph up, John? Or
yeah, I have. Just before we do that, Robert, why was it that the vaccine in the early days in Australia did seem to be effective, in fact was effective at preventing hospitalisations?
Right. Well, I think two things need to be stated. The first is that in Australia, we didn't see COVID virus for well into 2021 because we had lockdowns and we had closure of the country. We're an isolated country, and by closing the borders, we had a big impact on the virus coming. So when the vaccine came out, as opposed to England, where something like 2/3 of the deaths from COVID were already over by the time the vaccine came out. So the vaccine was, and as we were talking about the fact that the vaccine, they were getting negative immunity by 2022. So you'd already been highly sensitised. We hadn't. So up till the early 2022, in other words, a year or so after they brought out the vaccine, Australians were getting very good levels of protection, over 80%, which was terrific. That was great. But then the reality is that when people looked at that, they thought this was great. And as a result of that, the data they obtained back then is still being used today in Australia to recommend going to have more vaccinations. Look how good the vaccination is, way back. But of course, as we'll get on to this in a minute or two, the world has changed, the people have changed, we're no longer naive with respect to the immune response to the virus. But going back to that time back in 2022, there were 3 big studies done, really important studies, which said, let's not just look at COVID immunity and protection against hospitalisation or death. That's important, but let's balance that against the adverse events. And in each of those three studies, when they look at the dangers and toxicity of the vaccine against its benefits, which were real, the three studies all concluded that the net benefit was negative, that there were more problems from the vaccine than benefits from having the vaccine. Now, that's data that's all published. So if
so
we move...
basically that 80% protection was on a completely SARS coronavirus 2 naive population.
Exactly.
And that so you would expect some benefit there. Actually, interestingly, the vaccines were first sold to us, if you like, as protecting against infection, and then and then the owners, when they realised it didn't do that, the owners changed from no, it protects against hospitalisation, and they used information there from a completely naive population. Another way to look at it for this 80% protection is you could say that you didn't give natural immunity a chance in Australia. Would be another way to look at it. But that 80% that worked on a completely naive population is no way going to be any way applicable now, and the viruses have changed.
In fairness to the whole show, John, we can go back to 2021, the year when they first rolled out the vaccine, and the studies that showed the balance between toxicity and benefit, I'm sure can be argued both ways. And I wouldn't for a moment say there weren't people who benefited significantly from the vaccine, just as other people did not. But that argument is now 3 years out of date.
Yeah.
And now we've got to look at 2025. Yeah. And there's nothing special. In fact, we may come back to why the messenger RNA vaccine may be particularly damaging in this effect in terms of increasing the incidence of infection compared with, say, a traditional antigen vaccine, or even the DNA vaccines that came out at the same time as the messenger RNA ones. We may come back to that. But so I should have mentioned that's another factor that we need to put into this particular equation.
Yeah, and I would also argue that we probably don't know all the adverse reactions that we're going to get yet either. There could be some more still to raise their ugly heads.
Just before we started this video, John and I were talking about some conditions I have never seen in 50 years of clinical medicine as vaccine-induced abnormalities.
Do you want to run through that, Robert, or do you want to go on to the Canadian data?
Yeah, well, let's keep with the theme, John, on the Canadian data.
I'd like to do that, though. Let's come back to that.
The appetite. People want to know, really, are we talking nonsense or are we talking about a real problem?
And for that, we need data, which we now have on the screen, Robert.
Can I put my... This is the problem when you're seriously old and you've had your cataracts taken out.
Oh, tell me about it.
You've got to use glasses to read.
Oh, yeah. So this is the graph basically from the Canadian data.
Yeah.
It's a follow-up for a 33-week period, which is good.
Yeah.
So we're looking at the number of cases along the top here.
But let me tell you a little bit about this group, because
please.
I don't know them personally, but I've been following their work. To me, they're the best epidemiologists in the world in following this. It's run by a Professor Sarah Carrazza.
Yeah.
And Sarah, if you're looking at this, please answer my email, because I think you do terrific work. Now, what this group has done, it's an official group coming out of Quebec in Canada. They've been following religiously the impact of the vaccine on Canadians since the time of the rollout. And so they've had about 5 or 6 studies that have been published, and this is the most recent one. If you go to the first one, it does exactly what we were talking about a few minutes ago, John, and that is it shows about 80% protection against hospitalisation in health workers. And that was present for at least 4 months. The study was a 4-month study. So this was terrific. This was really good news. and reflects what we were talking about, that in an immunologically naive population, COVID naive population, or relatively then you have no suppressor mechanisms activated and dominating. You actually get, as you'd expect, like you do in influenza vaccines, you get protection. Now, what Karaza did is that she did every year, she kept doing these studies, and she found that year by year, the protection went from 80%, and you can see if you look at this graph, right at the beginning, this is, so we'll jump from the first graph, from the first study. Yeah, that's good, John. From the first study, which was done back in, as soon as the vaccine was rolled out, using the same methodology and the same general population, although there are different individuals involved, she found that things had changed dramatically. And it's very interesting because here you see what other people are showing when they look at a new variant vaccine against the variant that's still in the community. So if you look at what is, let's just go up to the top so you can get an idea of how things change. This basically shows how quickly the dominant variants change, so that you can see, just go right back to the beginning there, John. You can see at the beginning that light blue reflects the dominance of the variant, which was called XBB. It doesn't, we'll call it variant 1, that was in the community.
XBB,
So when the XBB, or the vaccine with the XBB came in, it was matched well against the community virus. And for the first 3 months, you can see 1 month, certainly the first month or so, it's matched extremely well. But see how the dark blue starts taking over? That's the JN1. That's, call it variant number 2.
Yeah.
And by the time you get down to month number 5, a dark blue comes in, which is the KP variants.
Yeah.
And here we are. By the time, this is the only vaccine that's around, the XBB. In terms of the vaccine cycle, you move 2 major mutations away from the vaccine you actually immunise them with, which of course has been happening year by year. And so you're a long way from the actual variant that you're vaccinating with by the time the new one comes up. So
it's a bit like Sydney Harbour putting up defences against battleships.
Well, that's right.
When the real risk is against nuclear submarines and space weapons and drones.
We did that when you guys were fighting the Russians in the Crimea. We were a bit concerned the Russians might bring ships down to Sydney Harbour. So we mounted guns on a little island in the middle of Sydney Harbour. It's a very good restaurant there now.
But they wouldn't protect against space weapons and drones and nuclear submarines today.
Finding down value, yes.
Yeah. Yeah, it's just, we're just protecting ourselves against ancient history. It's just preposterous.
Well, it's bizarre, and yet what is happening in Australia, and I'm sure it's happening everywhere else, is that we've got people saying, "Hey, go and get vaccinated," and they're using the data from way back in 2022 when it was, variants away, and people have changed, and let's just have a look at this because it really tells the whole story. I think this is a terrific epidemiology group because they tell the truth. As you can see, let's go along from looking at it from left to right. And you can see at the bottom it's 2023 and then it goes on to 2024. And the W stands for week. So you can see these are weeks after the original vaccine. They put in about 80%. You can see there, the one you're looking at the moment, W1619, they were pretty concerned because if you go up just a little bit, John, you can see that blue line going across. Yeah. That blue line is 0. In other words, anything less than 0 means negative protection, and negative protection means that group of people are getting more hospitalisations from COVID than the people who did not get the XBB vaccine.
51% more in that case.
Yeah, absolutely. And you can see that once you get past that first couple of months, from there on, those
Negative.
bars that you can see dipping down beneath the zero.
Yeah.
This is a terrifically important study. That means that's called they're like standard error bars. They
Yeah.
give you 95% of the population. So from about 2 months on, significant numbers of people are dipping below the zero. In other words, to make up that population, we're getting more admissions to hospital than the unvaccinated ones. And from there on, for about 80% of the vaccine cycle, you've got probably more chance of having worse outcome than a good outcome.
And this is looking purely at the benefit of preventing
this is not looking at adverse
hospitalizations.
events or side effects. This is simply looking at how well the vaccine is working and how well the vaccine is promoting problems rather. And this is not surprising. This is what you'd expect.
Yeah. It's not even how well the vaccine's working. It's not talking about preventing infections here, which was what we originally sold this on. It's only talking about preventing hospitalizations, nothing else.
Absolutely.
And
Now,
it's increasing hospitalizations by 51% at
many
one point.
people around the world now are familiar with the fact that you get more infections. I think the Cleveland Clinic study is probably the best where they show. Where you're probably familiar with that, John, where if you've had 3 vaccines, in other words, 1 booster, you've got twice the chance of getting an infection than the people who have not. What's important about this study, there are several things that are very important. One is it's a very, very good group. 2, when I say a good group, they actually do the study in a way, it's an observational study, because remember, there are no randomized clinical trials showing the vaccine prevents serious disease. Not one. They're all observational studies. And there's nothing wrong. A good observational study has value, obviously. But what they've done, they've got individual identification markers for the people because they have... So when they bring different populations together to get particular outcome measures, they can actually register against the same individual. The other thing is they age stratify. So these are age stratified results. They're not just looking at young people or old people. They're actually stratified in terms of the matching between the placebo and the active. So it's a very, very good study, and it's the only study I'm familiar with that's actually looked at the cycle of the vaccine rather than just the first 2 months.
Rather than just looking at what you'd like to see.
Well, which they want you to see.
Yeah. Can we look at some of the theoretical reasons for this? We've talked about this idea, Robert, that some things are going to stimulate immunity, but we can't have immunity going full blast all the time. We need things to bring it down again. What are the cells involved here, and what are the immunoglobulins involved?
Okay, let me just introduce that, John, by saying that one of the reasons people who are watching this should not be surprised about what they're hearing, perhaps for the first time, is that they would know that if you go to an allergist and you say, I've got hay fever, you're lucky if you leave the allergist without having a series of injections called allergy shots, right? You know about those, John? And
I've never actually seen them, but I've taught about them, strangely enough. Yeah.
Well, I've avoided them myself, but it's been a standard way of treating allergies, of inhaled allergens particularly.
Yeah, desensitizing vaccines,
For nearly 100 years.
Yeah.
Now, why does that work? Well, we now know why it works. It works because the respiratory tract, which is, if you breathe things in, the idea is to get the oxygen out of the air and get rid of the carbon dioxide, shame, that we make into the atmosphere. And at the same time, you're breathing in pollens and viruses and bits of this and that. And so the respiratory tract, it doesn't intrinsically know the difference between a bit of grass pollen or a virus. And so it's going to make the same type of immune response, or very similar immune response. And I mentioned that the elephant in the room of this local mucosal immunology is suppression. turning off. And the allergists worked this out long before COVID, 100 years before. And they said, if we give lots of shots, we turn off that nasty inflammatory response that that person with asthma or hay fever is making to the inhaled pollens or house dust mites. And that's exactly what we've been seeing on that graph, that if you have lots of shots of vaccine, be it flu vaccine or be it COVID vaccine or be it any other sort of vaccine for an inhaled challenge, be it a pollen or a virus, you're going to turn off your protective immunity. So there's no surprise about what's seeing. And in fact, as I mentioned earlier, it's been shown with influenza. So we knew about this. We should have predicted this. And when people started getting, it was a panic reaction. Well, probably a commercial reaction because they made a lot of money out of it. But
facilitated panic, perhaps.
Yeah, or we need more vaccine. More must be better instead of less being better. And very often less is better than more, and this is one example for that. Yeah. So we had this crazy situation whereby we were basically going to an allergist or a vaccinologist to get your vaccine or your allergy shots to turn off inflammation. No different. So what was the mechanism of that?
Yeah.
Well, you and I are exposed to hundreds of emails a day from people who have been studying this, and there's a huge interest in a particular antibody molecule in blood that's appearing in people who have 3 or more messenger RNA vaccines. And it's called IgG4. Now, what is IgG4? Well, everybody knows in blood there's antibody, and they know that antibody can mediate protection. Okay, that's pretty straightforward.
Yeah.
Now, the main antibody happens to be a protein which is given the term IgG, immunoglobulin G. It's now known that immunoglobulin G is made up of 4 different types, which are called subclasses. Immunologists are incredibly imaginative. Only immunologists would, certainly mucosal immunologists, go to very boring places for meetings and call it IgG1, IgG2, IgG3, and IgG4. IgG4 is present in most people in very small amounts. But the allergists found that when they were giving lots of allergy shots, they got a change in the amount of these subclasses. And particularly, the IgG4 one started going up. And they said, wow, that must be the mechanism of suppression of the unwanted inflammatory immunity that we're getting from pollens and house dust mite in people with allergic disease. Must be this. And then they looked at the IgG4 molecule and said, hey, this is different to IgG1, 2 and 3. It doesn't promote protection. It actually neutralizes and blocks these other molecules. So they said, game over. It's all due to the fact that there's a distortion of the immune response when you get overexposure to these inhaled antigens, virus or pollens, and it turns off the IgG, the good IgG that you want. But it's not as simple as that. I have a patient, for example, the amount of IgG4 in someone is a few milligrams. I have a patient who's got 20 grams of IgG4 in their blood, and he doesn't get any infections or any problems like that at all. He's got abnormal cells that make the wrong IgG4. It's like a tumour, but it's not a tumour so far. So IgG4 may or may not have a suppressive effect, but what we do know is that IgG4 is part of the distorted immunity that occurs when you overstimulate a mucosal immune response, either by inhaling a lot, natural infection, for example, with COVID, or you come from the other side and inject lots of spike protein into the body. And when you put the two together, you're likely to get a switch in the immunity, more of these T regulation cells or Treg cells that actually turn off the productive protective cells. And as part of that distortion, you get IgG4 becoming a more significant part of that spectrum of antibodies. Now, everyone's getting carried away about IgG4. It's a very important marker, and it's incredibly helpful in saying to you, John, look, we really are getting a turn-off. Not just are we seeing it in the patients with negative immunity, but we're seeing it in a test tube as a mechanism. But what we're really looking at, almost certainly, is the T regulation cells dominating in the control of this immune response. And I'll make one more point before I forget it, and that is there is another reason why messenger RNA vaccines, in my view, are promoting much more of this negative immunity, and that is we do not control the amount of antigen. I think if we go back to remember that course we did on Immunology 101 or something a long time ago.
All still available for public delectation and education.
It's not out of date.
No.
I think in the first one I would have talked about dose response curves, because
we did.
If I'm talking to medical students and I'm giving a lecture on immunology, I draw on the blackboard a curve that goes like that. And against it is low dose of antigen, high dose of antigen, and in the middle it's a good dose of antigen. So if you have low doses of antigen, you can get net negative immunity. If you have high doses of antigen, you get net negative immunity. In other words, when you're given a messenger RNA vaccine, you're not actually giving the vaccine, you're actually giving a nucleic acid message to make the antigen. We know, sadly, that this messenger RNA goes to potentially every cell in the body, making every cell in the body a potential factory for making the spike protein. Well, if we were talking about damage and adverse events, we'd talk about that making potentially every cell a target for autoimmune disease, because you're putting a foreign antigen on the surface. But we're not talking about that today. We're talking about massive, uncontrolled amounts of antigen in the blood. And there's probably some evidence that that in fact is happening, even though we can't measure the exact amount of antigen, because who knows how much is being made. And that is that you tend to get a higher level of antibody when you give a messenger RNA vaccine, and not much, but you get a slightly higher one. And that's, I'm talking about now the ordinary IgG antibody, and immediately after it, not downstream after they've had lots of vaccines. So this is saying that you're getting a big boost of antigen. But if you're getting a lot of antigen and you're doing it repeatedly, you're going to turn off this mucosal immune response, and you're going to distort the immune response, so you start seeing IgG4, and we also see various other expression of markers related to T cell depression, turning off the T cells in the body as well, which we won't complicate things by going into that. So
if I remember that increasing levels of IgG4, immunoglobulin G type 4,
yes,
is a marker for increased activity of suppressor cells, which
exactly
are going to reduce the immune response to a particular antigen. Is that basically correct?
Exactly. And the IgG4 may or may not have an additive effect on turning off or interfering with the function of the good IgG4, which is there to protect.
So in other words, the Bradford Hill criteria here are well satisfied, aren't they? We've got the epidemiological evidence that repeated vaccination is increasing hospitalizations. But we've got the mechanism of action. This is entirely plausible. More than that, you would have predicted this from your graphs that you've known about for decades.
Absolutely. I think I wrote an article in not because I'm special, it's what I do. It's no surprise. Yeah, I think the only surprise is that people haven't, right at the beginning, said, well, wait a second, be very careful about the way you cycle your vaccines, because as night follows day, you're going to end up with net suppression, net immunity, negative immunity.
Negative.
And you're going to promote the disease rather than prevent it. And that's exactly what we're seeing now.
So we've got it's just mind blowing. We've got negative protection and we've got all the side effects. It's just utterly
Yeah, and I
Bizarre
think one of the
situation.
importance of Sarah Carraz's studies is that she's not just looking at whether you're getting more infections, which could be mild. We're looking at serious infections. These are hospitalised individuals.
Yeah.
Hospitalised individuals. So, and Carraz's study in Quebec takes this to a different level. It takes it to a level showing, I haven't seen anyone who has honestly looked at the full vaccine cycle in terms of benefits. Everyone, and the most recent study I saw today, actually out of America, for the JN1, which is the current vaccine, in America today, the JN1 circulating virus that people are getting COVID from is less than 7%. And it's only been around for a couple of months. So it's doing exactly the same as we saw with the XBB, which we call Virus 1, did back in 2023, 2024.
We're back to battleships and nuclear submarines again, aren't we? We're protecting against battleships. So there's a 7% risk of battleships coming into Sydney Harbour, but that's...
I'll have to think about that one.
It's much more likely to be nuclear submarines. Yeah, and I mean, we just talked before we came on air. JN1, then KP, then XCC, then LP. I can't keep up with all these. But
I've got to write it down so I can remember.
So have I. I've written it down.
Here's mine.
Yeah. We both keep remarkably untidy notes, which is an encouraging point of harmony.
Yeah, well.
So there was some new data. 7% of JN1 at the moment. Now you
for the first time.
Sorry, Robert. Say again.
No, I just said I saw a couple of weeks ago that they were claiming that the JN1 vaccine, which is the current one, in America, was giving 40% protection. Now that's pretty. I mean, the WHO they don't get many things right, but I think they got this right. WHO stated that for a vaccine to be useful, it's got to be more than 50% protective.
Yeah.
Nothing's more than 50% protective anymore in the COVID arena. And so
they're breaking their own rules then. They're recommending vaccines that are less than 50% effective for maybe 3 months or less.
Well,
but even by their own criteria, they're not the.
In Australia, at least, it's for people over 18. In America, apparently, it's for kids over the age, 6 or 5 or 6. Well, when not one death in a normal, healthy child, as I'm told by people who know more about this than I do, that there has not been one recorded death in a healthy child in the United Kingdom or the United States of America from COVID. Not one. I mean, there have been kids that have had collateral problems, but not healthy.
It's just incredible. I mean, I'm still annoyed. I was sent for RSV. My surgeon, my doctor. No. You can never see my doctor, but I guess they're getting 20 quid a go or something, and they sent to tell me to come and get an RSV vaccine, respiratory syncytial virus.
Advertising.
I've talked to emergency doctors around the world on this, and none of them have ever seen a case of RSV sepsis in older people. It just doesn't. It's a disease that doesn't occur, and yet my doctor, who's supposed to look after my health, he wants to give me an mRNA vaccine to protect me against a disease that doesn't exist.
Did you tell your doctor that what's happening to the young kids that have been given the messenger RNA for RSV?
I would have done if I got a chance to see him, but of course that trial is suspended now. Remind me, what was happening? It was causing severe disease, wasn't it?
12.5% of babies, little infants, who were given the active got life-threatening RSV infection, because every kid gets RSV, not once, twice, they'll get it half a dozen times. I mean, it can be quite nasty, it's not good, but it's got a very peculiar type of relationship with the body's immune system, and we've known since the 1960s that you don't fiddle with RSV, because back then, with antigen vaccines, they were getting kids dying from overwhelming RSV infection. So it's going to be a lot worse, in my view, by putting in a messenger RNA vaccine where you can't even control the dose or the nature of the antigen that's expressed. And that's also probably important.
The fact that a vaccine got to trial that caused 12.5% of the childhood recipients who received that vaccine to get severe disease, I mean, to me, that's an unethical trial. It should never have got that far.
Well, the part that I laughed at, no, I shouldn't. I'm not laughing funny.
No, it's the ludicrousness of it.
It's so ludicrous that the vaccine trial was not just stopped; it was paused. Paused.
Yeah. Incredible. Yep. And now we're giving it to older people for disease. I know for a fact I've been exposed to RSV 500 times.
Probably.
I know that for a fact. I know that for a fact because I've looked after kids with it.
You probably had respiratory tract infections, mild ones, just like coronavirus or those. We all get. I mean, kids get 6 to 8 viral infections a year, and the young ones, 2 or 3 of them are almost certainly RSV.
Oh, I know for a fact we did because we used to get children in intensive care with RSV.
Absolutely.
Occasionally.
Absolutely.
And as adults, it never crossed our minds that we were at any risk of hospital-acquired infection, nosocomial infection from these children.
I've been an adult physician.
And we were intubating them and sucking them out, and there was no one ever got any RSV, including some clinical staff that were older. It was just no issue there at all.
Well, you probably did, but it didn't cause you many symptoms or any symptoms.
Exactly, because I've been exposed to it 1,000 times before.
A physician. I don't do hospital work now, but until moderately recently, I've been an admitting physician, and I must have seen hundreds and hundreds and hundreds of cases of pneumonia and respiratory tract infection. I've never seen an RSV infection. Of course, I've seen it, but of course, we've never bothered looking for it, and even now, when they're looking for it, it's very, very uncommon. Some people apparently do get quite sick with it, but it's certainly very uncommon. And the other interesting thing is that what we know about RSV infection and the immunity you get from the infection, it lasts just a few months, and then you get another RSV. So it's not as though, remember always that the best a vaccine can do, except for very rare examples, the best a vaccine can do is what the disease does, but the vaccine supposedly gives you the protection without the symptoms of the infection.
And then we've got the whole idea of giving systemic immunity to try and prevent against a respiratory infection, which we've looked at.
I think the idea is to stop that virus getting out of the airways, and as we mentioned earlier, if you gave a ground-up virus, you get the same sort of protection that you did with the RSV, but in an immunologically and COVID-naive individual, you get protection. But of course, that is something that lasts around about a year, and then we've moved on 3-4 years from that. Now we've created. I mean, it's very serious, John. We've created a population on the brink of COVID tolerance. We've created a population on the brink of COVID tolerance.
Just unpack that a bit, Robert. What do you mean?
Well, because 95% of my country has had 3 or more vaccinations with COVID.
Yeah.
If they get COVID, it's likely that many of them, because have a look at the graph, many of them will get more serious disease than they would have. Because they're on the brink, they're on the edge.
Right. So the vaccines are priming people to get more serious disease when they get natural infection.
Absolutely, when they get a natural infection. That's exactly that's what we're talking about. It's the natural infection causing more serious. They're putting them in hospital.
Of course, yeah, absolutely. Robert, there's quite a few people of watching these videos who haven't watched them in much detail before. So I wanted to just sort of brainstorm a bit of a list of reasons why we are concerned about mRNA vaccines. It's like an mRNA vaccine concern 101, really. I mean, maybe if I start us off, my first concern is that we're giving lipid nanoparticles, which are absolutely tiny, and that these lipid nanoparticles will go everywhere around the body, their systemic distribution. Now, the degree to which they're systemically distributed might vary from person to person. Some might get an inadvertent intravascular injection where it goes absolutely everywhere instantly. But they're so small they get everywhere anyway. So that's the first thing I'm concerned about, systemic distribution. Well, what sort of things would concern you about the mRNA vaccines that would indicate caution?
Well, I look at it very, very simply. The first is that messenger RNA vaccines potentially, as we talked earlier, can infect every cell in the body. And when it does that, it can create every cell into potentially a target for destructive T cells to damage it. And that means that not just traditional autoimmune disease, but a whole range of diseases we haven't seen or examples of which we've only seen rarely might occur. It means that there can be long-term post-COVID vaccine as well as post-COVID long COVID. I see far more post-COVID vaccine long COVID in my clinic than I do post-COVID long COVID, which is the one everyone knows about. And we know that something like 5 to 10% of people who get COVID will get long COVID. So you can imagine there's a lot of people out there with illnesses that have not been diagnosed, that they may have friends, and I'll tell you briefly what they get. They get chronic systemic inflammation. In other words, because they're expressing, in my view, the spike protein in a lot of cells and making this immune response, and the immune response is not getting rid of the COVID. And we know that the spike protein can persist in these people following vaccination for at least 2 years in the people with post-vaccine symptoms. I think the Yale study in America showed something like that. And another study recently showed that in the linings around the brain, you can find the spike protein up to 4 years after the injection. So we know this process can continue for a long time. And by creating chronic inflammation, there are two broad, non-specific type of things that occur. The first is the classic post-viral fatigue syndrome. Chronic fatigue syndrome is a term that's bandied around, and everyone watching this will know somebody with chronic fatigue syndrome. It can occur to 1% of people after a whole variety of vaccines, infections, and it certainly occurs after the COVID vaccine. And these people have basically two main features. The first is they have what I call energy-activated fatigue. That means they do something and they're absolutely stonkered. They can't do anything for the rest of the day. The second thing is they get brain fog or cognitive impairment, if you want to be a little more technical. That means the brain's not sort of functioning. My classic example was a patient I had when I worked at McMaster University in Canada many years ago. She'd come to my clinic and I'd always give her the first appointment, but she'd always turn up after I'd finished the clinic. And I said, why are you always late? And she said, well, I stand at the bus stop and I see McMaster University on the bus, but by the time I realise it really is my bus, it's gone. And I've usually missed 2 or 3 buses by the time I say I've got to be smarter here and get on a bus. Another patient was a maths teacher that I've had. I mean, I've seen hundreds of these people over the years. She had to give up being a maths teacher because she couldn't put 2 and 2 on the blackboard and come up with 4. It is 2 and 2 equals 4, isn't it? Yeah, something like that.
Strange, isn't it? Yeah.
The third thing a lot of these people get is what we call POTS syndrome.
Oh, yeah.
Now, POTS syndrome is, I would have seen over the years a number of people with POTS, but I'd see these people because it was fairly uncommon. I'm seeing these people now all the time. POTS syndrome is a condition where you change the regulation of your blood pressure. It's possibly due to a change in different autoantibodies. There are some groups around the world now measuring these and finding very high levels against the receptors for the nerves that control the tone of the blood vessels, which in turn determines the blood pressure. And so when they stand up, they fall over because their blood pressure drops. There's no way the body's blood vessels are constricting to keep the blood pressure going to the brain. They tend to get a fast heart rate. And these are the major features. They get a fast heart rate, postural hypotension. And this is particularly seen, I found, in the post-COVID vaccine patients. And then on top of that, because this is very different to, say, the post-glandular fever or Epstein-Barr virus fatigue illness, because you're also getting structural damage. Remember, throughout the body are expressing a foreign protein, spike protein in this case. And so the T cells, which are there to protect you against foreign protein, say, this is foreign, we'll kill it. So if it's in your thyroid, I saw a patient just last week where they had suddenly become underactive thyroid. This is not uncommon at all. And maybe they were going to get that anyway. Maybe they were prone to getting it because 2 to 4% of women will get Hashimoto's disease or hypothyroidism. It's very common. And what you find is that you not only get the common type of autoimmune disease, we're getting these bizarre autoimmune diseases. A very common one is people getting burning feet. Now, burning feet syndrome is caused by inflammation in the very small nerve fibres. And when you do a normal neurological examination, as you and I were taught to do, it's basically normal because you don't pick up these very small nerve fibres. But this has become very common, I find, in people with vaccine damage. Then, of course, you've got people with much more severe disease. You get acceleration of coronary artery disease and heart attacks, strokes. I remember my own family was admitted to hospital with a pulmonary embolus, nearly died from it. Another member was admitted with a cerebral event that was never properly sorted. These are people I know. These aren't the 1 in a million that the pharmaceutical companies tell you about. These things are so common.
And these can be debilitating. I've talked to people who are basically in constant, it's like the feet are in fires all the time. This is impossible to live with. In fact, there has been suicides related to people that just can't go on coping with these adverse reactions.
I had a patient recently, a gorgeous girl, who got menorrhagia, which is very well described, heavy periods after the vaccine. And it was so debilitating, she ended up having a hysterectomy. Now, mind you, she was, I think, she didn't want any more children.
Well, fortunately.
But she still, she was still in an age where she could have had children. And she was forced to have a hysterectomy, the only way to control the heavy breathing. No other reason for having it, just this post. And she had other problems with the post-vaccine. Yeah. So we're seeing this. And of course, people say, I've just got heavy periods, it's my age, I might have a fibroid, something like that. The other condition I was going to mention, I didn't, in the people with systemic inflammation, which I think is intriguing, is that all of us have a bit of tendinitis, a bit of bursitis perhaps, a bit of inflammation.
A bit stiff here and there.
Aches and pains in a left knee due to a little bit of inflammation. That can be accelerated in people who get systemic inflammation. So you've got a little bit of inflammation causing your tendinitis or Achilles heel problem. And a big study in Denmark showed that there was twice the frequency of significant tendinitis, bursitis, these inflammatory problems in connective tissue disease occurring when you heighten the systemic inflammation following the vaccine. So there are...
the amount of people that have come to me with these odd things, aches and pains and funny tastes in the mouth and, nervous sensations in the face and, the peripheral tinglings, the amount of people complaining of these things, which you could sort of write off as,
and
the rough and tumble of life, but...
Very small number of them are linked to what I believe is the likely cause. And it's because they're also common. And doctors are seeing these types of problems every day.
Well, I think it might be much more common than we think, but because they are common, they're sort of hiding behind that.
It's a cloak of commonality, isn't it?
Yeah. But my impression is more people are complaining to me about more things.
Yeah.
That's just an impression, but someone needs to do a study on that. The other thing that really concerns me is the complete inability with mRNA to control the antigenic dose.
Yeah, that's something that nobody wants to even. How often have you heard people talk about that?
Yeah, I mean, I say to all my student nurses, right, get your hand out. You give the right dose of the right drug via the right route to the right patient at the right time. You get it. You get those 5 things right every time. And this one, we can't control the dose.
You have no idea what the dose is.
So we could be giving. We can control, well, ideally, I'm not even sure this happens, we could control the amount of messenger RNA molecules in the vaccine, although there's been big quality control issues with that. But, the response that people make in terms of antigen could vary by a factor of 1,000. So,
absolutely.
So it's like me giving 1 milligram of morphine or 1,000 milligrams of morphine. I wouldn't say to one of my junior nurses, go and give Mr. Smith some morphine. Doesn't matter how much, just give him some. It's.
Fortunately, the dose. Yeah, well, I mean, we talked about the dose response curve, and I am. The interesting thing, John, to the best of my knowledge, and I've talked to people who make the other vaccines, there's been no description of increased IgG4, a marker of downregulation in people receiving classic antigen vaccines, which do exist in different parts of the world, or even the DNA vaccine. In fact, it's been specifically shown that they don't see it.
So interesting.
It's a feature of the one vaccine where you're getting uncontrolled dosage.
So we can say that the IgG4 marker for immune suppression is, as far as we know at the moment, specific to the mRNA technology.
Well, it's found at least predominantly with messenger RNA. It hasn't been described, to the best of my knowledge and my colleagues' knowledge, in any other form of vaccine.
Mm-hmm. Yeah. Now, I've never heard about the spike protein persisting in the meninges, the layers around the brain, the meningeal layers. So,
this was described about 6 months ago.
Right, because if you get meningitis anywhere, that causes, appalling symptoms. Cerebral irritation, for example.
Well,
behavioural problems even.
Going on inside, within the meninges, in the brain.
Yeah.
People who are getting these cognitive defects, which, I mean, I'm now seeing people who've had these things for 3 years, 4 years. So, it's consistent. Most consistent with the persistence of spike protein.
But that can lead to behavioural problems and irritability, and it can lead. People with head injuries are the most. It's classic. If you get a head injury, and they're like thrashing all over the place. But that's that can happen at a lower level where you have a little bit of meningeal inflammation or a little bit of head injury. And that can lead to grumpiness, perhaps a lower trigger for aggression.
A very good point. I think we've touched on that a few minutes ago, that what spike protein persistent in the body does, it can elevate a level of inflammation in the body, and if it's already up a bit causing some problems, you can imagine you're basically like it's a booster to the inflammation. And I think clinically that's what one sees.
Now, we can look forward to some good data. I don't know if you want to talk about this, Robert, or not, but there's some centres around the world are actually testing now for, we know we've talked to people, David Teacher, for example, who've demonstrated clearly the presence of DNA contamination in mRNA vaccines.
Yeah, great concern, and yet no one wants to take any notice of it.
I mean, why would DNA contamination be a concern?
Well, the DNA contamination is a concern, particularly in that they use a DNA plasmid called SV40, which comes originally from a monkey, which is known to promote cancer in certain circumstances. And you've only got to go back to the old polio vaccines that we all had in the 50s and 60s, that the Salk vaccine. It was made in monkey cells, and it took them years to actually show that there was a significant increase in certain cancers from presumably linked to that SV40. So we're right on the brink of finding this now. As you probably know, a letter's been submitted to the United States regulatory authorities from a group of lawyers and physicians just, I think, in the last week, demanding that there's a halt and an investigation of this contamination issue, which has now been described not just here in Australia but throughout the world, not in every batch but many batches. And it's just denied by the regulatory authorities when you have people like, people who ran the genome, the whole genome program. The head of that is one of the people crying out, you must do something about this. You're finding this sort of level of contamination. I think that the linkage here is to the potential genomic change that can lead to, on one hand, the production of long-term dementia problems and neurological degenerative problems, and on the other, cancer. And I know you've covered that in many of your own interviews and talks.
I mean, genomic change sounds like, doesn't sound too bad, but when you use the word mutation instead.
Yeah, well, that's what happens.
Yeah, absolutely.
I think I've always been concerned about the way people have always believed that the flow of information is from DNA to messenger RNA to protein. So you've got DNA, RNA, protein, and the DNA has the message that you inherit, and the protein's making with the structural and functional proteins in the body so that you can live and work and be who you are. And that there was never a reversal of this. Well, we now well know that there are enzymes in man that can reverse messenger RNA back into DNA.
Yeah.
And this has been shown in at least 3 or 4 observations and studies that you can, when you inject the messenger RNA vaccine, you can actually potentially, no one knows how much, what it does, where it goes, but you can actually potentially put that back into DNA. So if it gets into the germ cells, the next generation is going to be making spike protein as part of themselves. I mean, it's not fanciful, and it's not a theory. It's a potential that must be investigated and excluded.
While that theoretical risk is there should be a complete moratorium. I mean, there's no question about that in my mind at all. Why aren't people around the world testing for these things? I mean, we could be testing for spike protein, we could be testing for SV40, we could be testing for DNA contamination, we could be looking at all the cancers that people suffer from and seeing if there's any genetic changes in that, seeing if there's any spike protein in that. I mean, is this being done anywhere as far as you know at the moment?
The answer to your question, in my humble view, is that too many people now have too much to lose. You look at what's happening in all our countries. We have factories claiming they can make 100 million doses of vaccine a year, starting in Australia. And we haven't proved anything about the safety and the immunological integrity of response and things like that to these messenger RNA vaccines.
Now, we can do better than that. In my country, they're talking about producing 250 million doses.
Money involved. The institutes, the universities, all getting hundreds of millions of dollars out of this. They're all part of the process. So, who do you ask to get an objective view?
My thinking on this is that this recklessness, for want of to use a conservative term, this recklessness is probably not going to stop until the pathology generated becomes so patently obvious that it's like the nose on your face. You can't say it doesn't exist anymore. And until then, there's so much momentum behind this mRNA project, for want of a better word, that until it becomes blatantly obvious to the man or woman on the street, really, it's hard to see them going to stop, because there's still denial, there's still pseudo-intellectual sophistry dancing around this topic. I think it's going to require, sometimes in science, shifts happen all of a sudden. So, a good example is plate tectonics. People said, no, the continents don't drift around, but the evidence built up and up and up and up until one day, bang, everyone thought, oh, heck,
Yeah,
And
2 millimetres a year, I think, is the rate, isn't it?
yeah. But people said it didn't. Well,
I may
it
not be
varies.
around.
It can be a centimetre or two. But I know we're drifting apart from America at the rate of about an inch a year, I think. So some
I
might
thought
think it's slightly more than that in
it was
metaphorical
light
terms.
years. I thought it was light years.
Yeah, I think it may be. Maybe we could become the 51st state. That's an interesting idea, but we'll pass
No,
on from that.
52nd. No, you can't eat. Well, probably 53rd. Tonight, I think it was Greenland too, isn't it?
Yeah, there's a queue. But the serious point is, this is going to come out just the same way as other. Let's take the infected blood scandal in the UK. It will come out, but it's going to come out in the future. It'll come out all of a sudden. It could be several years away, and when it comes out, the scale of this is going to be like nothing ever seen before in the history of medicine.
Well, I think we've got to go through the cycle of the people who have been involved and they're out of the picture. I mean, you look at we've had, I think it's something like 2 or 3 national investigations into aspects related to COVID, excess deaths. I mean, to be frank, the excess deaths investigation was simply, if it wasn't so serious, would be just a joke. I mean, it was a joke.
In Australia.
Nothing is clearer when you look at the data that we're running a 12% increase in deaths, and it happened in states that never had a case of COVID, that had a lot of vaccines. I mean, you couldn't write about it. And we have the official thing saying, it's all somehow linked to COVID. And one of our leading institutes just last week came out and said, well, we've seen these excess deaths, but it just shows you the lingering effect of the pandemic. Well, in a sense it is, but it's not the COVID virus. Look, I'm not suggesting for a moment that it could be the vaccines, but it certainly is something. It just happens to relate very closely to the vaccine spin out.
Indeed, Robert, as always, we could go on forever. I do have a list of other things here, but I'm not going to inflict them on you. Maybe for another time. Fascinating things like pre-amyloid fibres.
Oh, wow, yes. I think that's really one of the most interesting.
Do you want to do that one, or do you want to go and get back to your life?
My favourite anecdote about this, and I think it encapsulates the whole story, maybe a good way to finish, of COVID. The Nobel Prize in 2023 was given with warp speed to 2 individuals, and the major reason they were given is that they were able to change messenger RNA into a more stable, more infective form that sits tightly on the ribosome, the factory for proteins in the cell. And they took out one of the, as most people know, there are 4 bases in RNA. And one of them is uracil.
Yeah.
And uracil, they took the uracil out and put another base called pseudouracil, which made it more stable, more sticky. Well, the Nobel Prize was given 3 months after the Nobel Prize was given for this very innovative, clever technology. The Cambridge group came out and said, well, wait a second, putting the pseudouridine in the messenger RNA that was being given as a vaccine, in 10% of the readouts, 30% of the readouts, it's 1 in 3, were actually getting a false slippage of readout and getting false proteins. And a lot of those false proteins are in a form known as beta pleat. Instead of being in helixes and winding, it's in little sheets like this, which form amyloid as an insoluble protein in tissues, which
basically just clogs up the tissues with this pathological protein,
which is the basis of certain forms of dementia.
Yeah.
What did the Japanese show around about the same time? That there was a significant increase in this particular type of dementia, and more importantly, there was an even greater increase in the country of, it was Japan or South Korea, I think it was Japan, that the pre-dementia cognitive defects, where people get woolly and can't remember things like me, then
that
was increased far more. In other words, which made sense that if you had a progressive process that takes years to happen.
Yeah.
And this is incredibly scary. Now, that happened 3 months after the Nobel Prize was given for the invention, was shown to be the basis of toxicity.
So what's happening here is normally there's 3 bases on the molecule, on the DNA molecule or the RNA molecule would code for. Yeah, there's four bases, but there's three would code for a particular amino acid.
That's true. Yes.
Yeah. So the triplet code. So yeah. There's 4 bases. 3 would code. But if you slip one, then you're actually reading them in the wrong order, and you can get the wrong amino acids and the wrong proteins.
It's like an old-fashioned tape. You shift it up.
Yeah.
The whole thing changes, and so you make a different protein.
Yeah.
It's
like when you're making a video, if your audio track and your visual track go out of sync, then you start look like you're talking a foreign language.
That's right. You're talking Japanese or Korean.
It's called frame shifting.
Frame shifting, exactly.
Yeah.
And it's a real thing.
Yeah. So I mean, again, it's a bit frightening to think about, but how many people could be prone to develop dementia at a much earlier stage?
Well, but I tell you what, scientists, we're all a bit funny. The same Cambridge group last week, you may or may not have seen it, John, came out and said, we've got a way now of remedying. They're lining themselves up for the next Nobel Prize. We can remedy this pseudouridine by doing a few tricky things here and there. So I guess there'll be someone then showing that. So we're going to get a new breed of messenger RNA vaccines.
It's like an anti-missile or something, isn't it?
Like that.
Yeah. Right, we're going to finish, Robert. Thank you very much. Love that map behind you. It's a former great country, isn't it?
I did that for you, John.
Thank you. We appreciate it.
A great map maker called DeWitt back in 1660, and I'm not sure if England's changed much since then, but it looks the same to me. But I thought it would make you feel very comfortable looking at a DeWitt map of England.
Looking at old England makes me feel very comfortable, Robert. Looking at current England makes me feel, Scotland, Wales and Ireland as well, of course, makes me feel slightly less comfortable. But as always, Professor, thank you so much. Just what wonderful, mind-blowing, fascinating stuff, but with such serious implications for human brain suffering and death.
I think what I'm hoping we're leaving with people is that they must ask questions themselves. There's nothing that's bizarre or highly complex. This is pretty simple stuff. That go back to the basics and ask yourself, is this intervention in medicine, it's a new one, has it been properly tested? Has it been around long enough to know about adverse events? Is there reasons from the biology? And this is where things have gone terribly wrong with messenger RNA vaccines. That the biology and what we've known from 80 years of flu vaccines, we knew all these things were likely to happen. It's that crazy.
Yeah. I mean, we talked to Angus Dalgleish lately, Professor Dalgleish, the leading oncologist, and he said he predicted this back in 2020. But, why weren't the government knocking on his door saying, look, we've got these professors with immense expertise, and in all due modesty, you're certainly in that group, and people like Angus Dalgleish, and yet, why would we bother having all these clever professors if we're just going to ignore them? In fact, worse than ignore them, poo-poo them and punish them.
Well, I was just told 2 weeks ago from a very, very senior immunologist colleague of mine that there was only one immunologist on all the committees in Australia looking at COVID, be it vaccines, treatments, whatever. One, who I happen to know, he's a good guy and very smart, but in a totally different area to this. So there was no input of knowledge into the analytic process.
Yeah. It makes you wonder why we bothered, really, but...
well, probably tells us why we bothered.
Well, indeed, it does. No, I don't want to be cynical because, I know that you've helped tens of thousands of patients throughout your career and now, probably, interestingly, helping even more with this mass communication that's been thrust upon us.
I don't know about that, John, but I
No,
think
I
that all I'm trying to do is tell people that there's nothing clever. Immunology makes it look hard by using the names of mice that never appear, having cytokines with unmemorable names, without
Yeah.
just saying all it is a communication between cells. You know, it's a message that goes.
Yeah.
It's all very simple stuff, but
Well, I understood everything you've said today, and if I understand it, then you know, anyone who watches this video a couple of times should get it all.
perhaps if there are people who haven't understood, and I know these things are so different, and they're different to what you're being told. Go back. I will tell you where you can read this paper. John, can you put it up?
Certainly, we can put the links.
I would say to every one of you, go back and you can just Google it. It's very easy. It'll come up. Read the Google, and then go back. Use her name to trace back the various studies that she's done from 2021, because right at the beginning she showed, and everyone was using this stuff, saying, "Wow, look how good it was," and it was real. You know, they really were protecting. And then the more she did it, the protection went down, down, down until the latest. And just today, it looks as though the same is going to be occurring, as one would predict with confidence, with the current JN1 vaccine.
Yeah, yeah. Great, Professor. Thank you so much. So it's good evening from Australia and it's good morning from England. Thank
Back
you.
to the rugby.
Absolutely.